Good afternoon or evening, depending upon where you are. And I'd like to thank the Cancer Genomics Consortium for inviting me to give this talk. It will be a little less perhaps scientific and more clinical than the other talks. So I hope you enjoy my talk today called Do No Harm. Basically, I'm going to talk about the state of genetic testing, mostly for hereditary breast and ovarian cancer. I'd like to give a summary of the history of genetic testing, some management recommendations, including a highlight of risk-reducing surgery, and then talk about common mishaps and misconceptions that occur clinically. And the talk will be sprinkled a little bit with my editorial comments, which I think I'm deserving of based on my age. First, I found this timeline, which I think is a refresher for most of us. In 1991, BRCA1 was linked to chromosome 17. Myriad Genetics was founded, and in 1994, BRCA1 was patented by the University of Utah, the National Institute of Environmental Health Sciences, and Myriad Genetics. In 1995, the patent for BRCA2 was filed, and in 1998, those patents were, 1997 and 1998, those patents were granted. My personal experience during this time, I was a perinatologist working at Oregon Health and Science University and became interested in genetics mostly through prenatal diagnosis. So from 1999 through 2001, I did the clinical genetics residency and became boarded in medical genetics. At that time in our clinic, we were offering BRCA testing to women who met a personal history or family history. The criteria was quite strict. Insurance companies offered variable coverage for the very expensive testing, and therefore our ability to offer testing was somewhat limited. A big change in our practice came in 2013, and I gave a lecture at that time called The Perfect Storm, which talked about the intersection of the Supreme Court decision against Myriad holding the patent for human genetic material. And at that point, next generation sequencing was really taking off and becoming much less expensive. And the Angelina Jolie effect, which was documented in the New York Times twice, once in 2013 when she disclosed that she had a BRCA1 mutation and decided to have a double mastectomy, and then her second disclosure in 2015. And both of these things raised the consciousness of people, at least in this country, regarding breast cancer risk associated with these hereditary breast cancer genes. And that's just a picture of the Time magazine cover from 2013. So at that time, there were recommendations for surveillance and risk-reducing screening or surgery for BRCA mutation carriers. Mammograms beginning at age 25, clinical breast exams twice a year, self-exams, and chemoprevention, including selective estrogen receptor modulators like tamoxifen. Risk-reducing surgery in terms of a risk-reducing mastectomy was discussed as an option, and that is still the same today. It's an option, not a recommendation. And then, of course, there were recommendations for screening and or surgery to reduce the risk for ovarian cancer associated with having a BRCA mutation. Since then, there are other management recommendations, which include surveillance not only by mammograms, but also MRIs. The downsides of MRIs are they're expensive. There's concerns about gadolinium injection, which is required for a breast MRI. Advantages are screen-detected cancers are usually smaller and more likely to be node negative with a breast MRI as opposed to a mammogram, particularly in younger patients who have more dense breasts. We have come to learn that although selective estrogen receptor modulators are available, they are not very well tolerated, and therefore the uptake of that recommendation is pretty low. Most women do choose to have an oophorectomy, which is protective against both breast and ovarian cancer. And now I want to talk a little bit about kind of the setting of breast cancer and women's concerns for breast cancer, and adding on that layer of having genetic testing for hereditary breast cancer. So the breast cancer incidence across the world, but in the United States, is increasing. We don't know whether that's just because of better screening or because of environmental factors, early menarche, things like that. Breast cancer mortality, fortunately, is decreasing with better treatment options. There was a 2016 campaign, the Choosing Wisely campaign, which was aimed at decreasing the rate of mastectomy as treatment for breast cancer. However, despite this, the national rates of contralateral prophylactic mastectomy in the U.S. are increasing. In other words, if a woman has breast cancer not related to a mutation in any breast cancer gene, even despite that, she may choose to have a contralateral mastectomy. And some of this is driven by I would say there's a lot of fear about breast cancer among women in general. So I did want to talk a little bit about the types of mastectomy because this does impact complication rates. Radical mastectomy is an en bloc resection of the entire breast, including the internal mammary and supraclavicular lymph nodes and the chest wall muscles, and that's depicted over on the right. We don't do this anymore, and there's a lot of complications and morbidity associated with that particular surgery. A modified radical mastectomy is also not done very often because the lymph nodes are removed and there are complications of lymphedema. Total or simple mastectomy, it's mostly what's done. The entire breast and sentinel lymph nodes are removed, but the muscles underneath the breast are left intact. And the morbidity of that is less. And then there is the skin-sparing mastectomy, which removes the breast and the breast tissue and the nipple, but leaves the skin over that intact, and that helps in terms of reconstruction. And then there's the nipple-sparing mastectomy, which leaves the skin, the nipple, and peripheral breast tissue intact, and that is actually not recommended for individuals who have a BRCA mutation. So the benefits of mastectomy, prophylactic mastectomy, especially in BRCA mutation carriers who have a very high risk for breast cancer, is very well studied. It definitely decreases the risk of a second breast cancer by 95%, mostly in younger women, because your risk to develop a second breast cancer if you have a BRCA mutation is largely dependent upon age. It is cost effective versus surveillance. If you just look at the cost of having a mammogram and a breast MRI every year for 20 some years, 40 some years, depending upon when you find out you have a BRCA mutation, definitely having the surgery is less costly. Satisfaction, it does provide a lot of women with satisfaction in terms of decreasing their anxiety about their risk for breast cancer. However, there is no evidence that a bilateral prophylactic mastectomy increases survival from breast cancer, although it may in younger women. It's sort of that's where they'll cross the line of perhaps being some benefit. However, the downside of the bilateral mastectomy is the complication rate is quite high. Early complications include bleeding, infection, anesthesia, deep vein thrombosis, just from the surgical complications. Intermediate complications are mostly related to reconstruction and include flap loss, implant loss, unanticipated revisions. And later complications include dissatisfaction with the cosmetic outcome, phantom pain, persistent numbness or tingling, and an impact on sexuality because basically you have no sensation in the reconstructed breast. And this is just a table I found in an article where they reviewed like 2,000 some mastectomies. And they looked at the 1-year postoperative complication rate, and this was done out of Sloan Kettering. So if you just focus on the statistics, the percentages, the first was an implant with an extender, that's the tissue expander, that's the first column. The second column is a pedicle transverse rectus abdominis musculocutaneous flap. The third column is a free tram flap, and then the last column is the deep inferior epigastric perforator techniques. And going from left to right, they're more complicated surgeries. And I just want to call the attention to the complication rate, which varies from 24 to 46% if you go across the first row of any complication, and reconstructive failure, which is much lower than that. But it's not a surgery without complication. And lastly, this was an article from the, I think it was a New York Sunday Times, or no, maybe it was an op-ed from the New York Times a couple years ago. This woman experienced, she was tested, she had a high-risk breast cancer mutation, and she decided to go ahead with a bilateral mastectomy. And while she might have been satisfied with the cosmetic outcome, she was never told that she would not have any sensation in her breast tissue. And I think this just highlights the fact that if a person has a mutation and they're in BRCA1 or BRCA2 or some of the high-risk breast cancer genes, and they're considering a bilateral mastectomy, I always tell my patients to do their homework, to visit a couple different breast surgeons and plastic surgeons, and maybe go online with some of the support groups like Facing Our Risk of Cancer Empowered, because this is something that you really need to make sure you want to do, because you can't undo it. So this brings me to the do no harm part of my talk, which hopefully is going to make sense. So as I said, the risk-reducing mastectomy does decrease the risk for second breast cancers, but it's in some of the high-risk breast cancer genes like BRCA1, BRCA2, P10, TP53, patients who have a lifetime risk for breast cancer that exceeds 50%. As I said, there is no demonstration of increased survival from breast cancer. Obviously, some of these patients are at increased risk for other cancers, but having a double mastectomy is not going to impact that. And then the last question is, are there mutations in any other genes for which this should be an option? Because we have patients who ask those questions when they undergo testing for hereditary breast cancer and have mutations in some of the other breast cancer genes. So going back all the way to about 2007, other candidate genes for hereditary breast cancer were proposed based on the pathway of BRCA1 and BRCA2 with other Fanconi anemia genes. And early studies looked at cohorts of patients who looked like they should have a BRCA mutation based on their age at diagnosis, their family history of both breast and ovarian cancer and potentially other cancers. Those individuals did not have a BRCA1 or BRCA2 mutation, and so they were tested for other candidate genes, and a certain number of individuals were found to have mutations in these genes, so they were kind of proposed as potential inherited breast cancer genes. This is just a table which I took from Cancer Network, just sort of giving you an idea of what kind of testing can be ordered for hereditary breast and ovarian cancer. And it ranges from simple BRCA1 and BRCA2 testing to very large panels of genes, the largest of which is at the end, which includes 63 genes. So these are commercially available. Individuals or practitioners who are ordering testing can choose from any of these panels. And obviously, most of the time nowadays, we don't just order one or two single genes, because there is evidence that there are other genes that are associated with an increased risk, and there are recommendations for screening for those individuals. The question is, though, is bigger better? Obviously you're going to get a higher diagnostic yield. A certain proportion of hereditary breast and ovarian cancer is not due to BRCA1 and BRCA2, I feel like we should include some of the moderate risk breast cancer genes for which there are NCCN recommendations. The second possible result from the very large panels is you'll get an unexpected result. You get a positive for a mutation in a gene that's not at all associated with breast cancer or ovarian cancer, and just randomly shows up, and then you have the problem of counseling that individual and disclosing those results to the family. The VUS rates increase, and I'll talk about that in a minute, the variants of uncertain significance. Most of the time I don't pay too much attention to them, but once they're out of my hands and my patients' hands, they can be used by relatives, even though that is not the recommendation. And then the third problem with the large panels is identification of mutations in genes for which risk is unknown. There are genes on the 80 gene panel, or the however many gene panel, that actually I don't know what the risk is, and I don't think there's a lot of evidence that there is risk. So I always tell my patients, if they're contemplating having a larger panel, that it may not give them any more information than what their family history would give them, but it may be useful for their children or their children's children. And this was just an interesting study I read, and I lifted parts of this table out of the study. It was a lot of patients who had genetic testing, and the number of genes on the panel varied over time. So I can't remember the timeline, but obviously some of the panels added genes. So that's why you see like breast next 14 to 17 genes, cancer next 22 to 32 genes, cancer next expanded with a max of 49 genes. A lot of patients were tested. Interestingly, not so many with the largest panel. The percentage of positive results or likely pathogenic results increased, obviously, with the number of genes that were included, because it's more inclusive. But look at the VUS in the rate in the last panel. So it went all the way up to 40% with the largest panel. So that definitely is a downside when you release those results to patients and families. They can be misused. So the other problem with these panels is that although a genetic counselor or geneticist realizes that mutations in these cancer genes do not confer equal risk, I can't say that that's always true for both non-genetic providers who are ordering these tests, and certainly in patients. So we have what we call high-risk breast cancer genes, including BRCA1, BRCA2, PALB2, TP53, and we know that women who have mutations in these genes have a 50% or greater lifetime risk for breast cancer. We have moderate risk breast cancer genes for which the lifetime risk is 20 to 40%. An example would be ATM, CHEK2. And then we have some newer genes where we don't really have a good estimate of what the lifetime risk is, and we base risk on family history models. So I guess what I'm trying to say is that there are some people who think that a moderate risk breast cancer gene is equal in risk to a high risk breast cancer gene, and that leads to confusion and with patients and recommendations by surgeons and primary care doctors that aren't necessarily in following NCCN guidelines. So I put this in here because I sort of did my training in the 1980s and 1990s when this thing called evidence-based medicine was a big deal. And you, in OBGYN, you were not allowed to do anything, or I should say you were not allowed, but we had to follow evidence-based guidelines for everything. And, in organizations like the American College of OBGYN published guidelines based on evidence. I think that the genetics world has strayed a little from evidence-based medicine, I hate to say, and this is part of my my opinion part of this talk, and not necessarily held by everybody who does this. This is the NCCN guidelines, and thank God for the NCCN guidelines because they do address recommendations for genetic and family high-risk assessment for breast and ovarian cancer. And they have a set of guidelines for BRCA1 and BRCA2 mutation carriers, a number of other high-risk breast cancer genes. And then they have tackled the problem of making recommendations for some of the genes that are on the breast cancer panel testing. However, you'll see for the ATM gene, there's insufficient evidence to recommend a bilateral prophylactic mastectomy. The same for BRIP1 and CDH1, and it goes on and on and on. I just took a screenshot of this. What I wanted to point out on here is at the very bottom it says all recommendations are category 2A unless otherwise indicated. So if you go back to categories of evidence and consensus, back to evidence-based medicine, category 1 is based upon high-level evidence because there is uniform consensus that the intervention is appropriate. Category 2A is based upon lower level evidence. However, there is uniform consensus that the intervention is appropriate. So, basically these recommendations are not based on like randomized controlled studies and, high level evidence. And this is just another screenshot that I don't need to talk about, but it addresses some of the other moderate risk genes like CHEK2 and NBM. So all of this makes for very challenging clinical scenarios that are commonly encountered in genetic testing for hereditary cancer syndromes. First and foremost, there is the misinterpretation of negative results. In other words, you have a woman who doesn't have breast cancer, but she has a sister, a mother, an aunt, a grandmother, all who had breast cancer. She doesn't have a mutation. Sometimes this is misinterpreted as her not being at risk, which is definitely not true because there are models that you can put family history in which would clearly increase her risk just based on having those relatives who have had breast cancer, despite the fact that maybe even we tested someone who did have cancer in the family and they didn't have a mutation. If we tested someone in the family who did have a mutation and she didn't, then that would make her go back to the general population risk. Patients are referred often for testing for family mutations. We always ask for a copy of the family member's mutation because oftentimes it's billed as a BRCA mutation and it's not. It's a CHEK2 mutation or an ATM mutation, so different set of recommendations. Or worse yet, the patient was referred and her family member had a VUS in some gene and we wouldn't test them at all for that. I will talk a little bit more about the perils of the VUS, but then the last category, or the third bullet point, which doesn't pertain so much to high-risk breast cancer genes like or genes that we've been testing for a long time, but there are discrepant ClinVar classifications. So, one lab will classify a mutation as likely pathogenic, and another lab will classify that mutation as a VUS, and that becomes very problematic when you're dealing with family members who get tested at different labs. I mean, I think you can imagine the confusion that causes. And I did want to talk briefly about the perils of the VUS. This happened in Oregon, and my time is running out, but so a woman who was unaffected, had a genetic testing from her OBGYN, and her result came back that she had a VUS in MLH1, which is a Lynch syndrome gene. She went on to have a mastectomy and a hysterectomy and a oophorectomy, and I believe this has resulted in a lawsuit which may have been settled by this point. I think this kind of thing happens because commercial laboratories market testing to non-genetic providers. The providers don't necessarily read the report, and I do have to give kudos to the lab because their reports are generally very comprehensive. And third bullet, it is very important to request a patient's test report prior to making these kinds of recommendations. So I think that at this point, it's very important that we continue to try to educate providers and patients about the different kinds of results and the differences in risk between genes. I think that communication and sharing clinical information with laboratories is very important in terms of resolving VUSs. I don't use larger panels very often because of some of these problems, but I think that if a patient is interested, they need to have informed consent. And I don't even want to talk about direct-to-consumer testing and or universal testing. Basically, I think the cat is out of the bag. Unfortunately, we should have done more research before we offered these larger panels. But currently, laboratories doing the testing are generating more research and information about these other genes. And I apologize for all my ums.